Frequency Podcast Network. Stories that matter, podcasts that resonate.
There was a time where the drugs we now unquestionably reach for when a headache starts to kick in or your back starts to hurt, like Advil or Tylenol, were once in their experimental, potentially taboo phase. But as medicine continues to evolve, so do the ways experts recommend treating our illnesses, be it mental or physical. The use of psychedelic drugs, although commonly used recreationally, has been in its medicinal research stage in recent years, with a new study showing a single supervised dose of LSD, also known as acid, relieved anxiety symptoms for several months. Now, although the use of psychedelic drugs has promising health benefits, nothing is conclusive, and unsupervised microdosing and full-dose usage does have real, sometimes life-altering effects. But the curiosity for alternative medicine is out there, and for the millions who battle with mental health symptoms daily, the choice of an alternative could not only be life-changing, but life-saving. I'm Maria Kestane, and today on The Big Story, we're talking to Dr. Roger McIntyre, a professor of psychiatry and a professor of pharmacology and toxicology at the University of Toronto. Thank you so much for joining us today, Dr. McIntyre.
So wonderful to be with you and great to have this conversation.
So the use of psychedelic drugs in general isn't, necessarily as popular maybe as weed, or other mainstream drugs. The odds of seeing someone eat a magic mushroom on the street versus light up a joint, very, very different odds there. But microdosing is kind of that entryway or socially acceptable soft launch into making psychedelic drugs a bit more socially mainstream. What is microdosing exactly? How does it work?
I agree with your comment. We certainly are seeing much more use of psychedelics, broadly defined. Secondly, we're seeing the trajectory of use going up. So it's a high use and the trajectory is going up. So you're exactly correct in what your impressions are. And I also agree, it's probably not as high as cannabis consumption, but it's going in a similar direction. It's going up. And we saw this with cannabis 10, 20 years ago, the upward trajectory. You mentioned microdosing. And microdosing, at first glance, seems to be self-evident what that means, but in the world of science, it's not even clear what that even means. What it's generally meaning is when someone takes a psychedelic, but the dose of the psychedelic they're taking is not causing any pronounced, kind of sensory changes or cognitive changes or any changes in consciousness. And this has been really promoted and celebrated by many groups online and certain Reddit groups and things of this nature. And people make claims that it has been beneficial for not just creativity, but for overall well-being, overall social engagement. It sounds pretty good. The scientific community is still scratching our head, quite frankly. We don't yet have any compelling, substantial evidence that it's safe or effective in any of these claims that are made. It doesn't mean that those claims aren't true. We just haven't been able to prove that in good science. So how common is microdosing? GOK. God only knows, because no one really knows how common it really is, but it's certainly common. And I would just put out there that, again, we don't know what it means to microdose. There is that definition we have, it's a low dose, not causing any kind of psychoactive effect. But in many ways, that's sort of a vague definition because that's obviously very inter-individual influence. So yeah, this is very common practice.
What drugs are typically used when people microdose?
Well, I think we need to be very clear in terms of what our glossary is here. Now, psychedelic means different things to different people. It's a term that was coined in 1956 by a psychiatrist. Coincidentally, Canada, has put certain things on the map, but actually it was a British psychiatrist working in Saskatchewan who coined the word psychedelic, and it sort of means mind manifesting. And historically, that's sort of referred to psilocybin or LSD. That got extended into DMT and even to 5-methoxy-DMT. But the tent got bigger and bigger because people started using the word psychedelic to refer to anything that causes pronounced psychoactive effects, including what we call empathogens or entactogens like ecstasy, or even what we call dissociatives like ketamine and related drugs. But to keep the conversation more narrow, because when people talk psychedelics, they're usually referring to psilocybin or LSD type drugs, usually. And this is, in fact, really where most of the emphasis has been in terms of not just the public interest, the media interest, but also, I think, in terms of the community of science and trying to develop new therapeutics. How common these drugs are being used is really anyone's guess. But we do know that these are drugs that do have predictable, well-known psychoactive effects, and effects that are still being, if you will, characterized by people like our team and other teams in the academic community.
So you say when people microdose, they don't really have any profound, conscious changes, or, things don't really change a lot for them compared to when they do full dosage of psychedelic drugs. Why do people microdose then? What are they looking to feel that they can't feel with like a more mainstream drug like weed or alcohol or other things like that, or even Coke?
Yeah, well, certainly people do things for reasons they're aware of, and they do things for many reasons they're not aware of. But for reasons that they say that they are aware of, what they often will put forward is they will say that I heard or have had my own personal experience where microdosing really enabled me to be more effective in the boardroom or more effective in some of my workplace activities or creativities. Many would say it's reduced their anxiety, improved their mood, maybe even reduce some of their inhibitions. In other words, they really describe a sense of vitality, a sense of engagement, a sense of well-being enhancement. And that's certainly compelling. And you've heard this in testimonials, as I said, from various sources. Admittedly, it's a bit tricky for us in science to measure creativity, but there's other ways we can measure it. There's paradigms we have for that. And there's been studies that have been done, albeit small, but some very rigorous studies. And this is an important point for your participants, people listening in fact, should be aware. We don't yet have any compelling evidence that using a low dose, I prefer to use lower dose than microdose, because again, microdose refers to a dose of a psychedelic that's falling below that dose that causes a psychoactive effect. But the drug still has a brain effect. It's still having an effect on the brain in some way that we're still trying to characterize. And secondly, everyone's different. What might be a microdose for you may not be a microdose for me, and vice versa. So that's why the term microdosing is really inexact. It doesn't really have any scientific meaning, but it's conversationally referring to below the psychoactive effect dose. But again, it's still having an effect on brain. And I would put forward that we do have some evidence based on MRI studies that very low doses of psychedelics like LSD, even when really, really low, like 10 micrograms of LSD, 5 micrograms of LSD, the person may say, I don't really feel anything. But on the MRI scan, we're starting to see changes in their brain occurring. So that's why we in pharmacology we kind of get uncomfortable, because words matter. Words matter. And we get uncomfortable with the word microdose. We prefer low dose versus high dose.
So let's get into that low dose versus high dose. What happens then when a person takes a high dose or a regular dose of psychedelics? What's the brain activity doing?
Well, it's still being looked at, but in a nutshell, I think what we have learned is when you take a psychedelic, what's occurring is what happens when you take ketamine, or when you take a SSRI for depression, or when you speak to a cognitive behavioral therapist. What's happening is it's resetting what I call CNN, the circuits, the networks, and nodes in your brain. Our brain is comprised of a series of networks, just like the motherboard on the PC at home. And what happens is in mental disorders like depression, anxiety, PTSD, the list is long, what they all share in common is something has gone awry with the architecture and the function of these circuits in their networks, how they're all interplaying with each other. And what we can see with psychedelics like LSD, and we can see with treatments like psilocybin, is that this abnormal network is being reset. And it's being reset in a direction towards what appears to be normal. And it's doing so fairly rapidly. Now, that's the circuits, that's the networks. Many of your participants would know that psilocybin targets serotonin. But keep in mind that those are just the neurotransmitters that the drug is targeting. All drugs work through neurotransmitters, but the neurotransmitters trigger what I would call the cascade of events, and a cascade of events then result in this network reorganization within the brain. So it's true. It is true that depression is an abnormality in the brain circuitry, the network architecture and organization, and these drugs are rapidly resetting it.
So it's like a bit of a reboot, you'd say, a
It
reboot and a
is.
reset.
It really
Interesting.
is.
Where I'm curious to know in terms of social acceptance and tolerance of using psychedelics or low dosing psychedelics, where does that fall in the spectrum of social acceptance? Do you think it still has this taboo rep to it, or do you think it's a bit more acceptable in society nowadays?
Well, I think we're seeing that playing itself out in the political landscape, the legal landscape, the Netflix landscape. How often you watch Nicole Kidman shows where she's taking shrooms? This would have been unthinkable 15, 20 years ago. So I think you're seeing it play out in popular media. You're seeing it play out in what's happening. State of Oregon, for example, is often put forward as an example. There's other examples across America where you see, in fact, states that have changed laws to either decriminalize or even to actually fully legalize the psychedelics. So clearly things have changed. I think the big change, quite frankly, in the academic community, going way back 50 years ago, when the Drug Enforcement Agency in the United States classified psychedelics as what they call level 1, which means these are no good drugs. They're just harmful drugs to humanity. They should not be studied. You weren't really allowed to study these drugs, actually. They were highly illegal. And although they remain scheduled as so-called Schedule 1 drugs, the academic community has now been permitted to study this. And I think to keep going with that, most drugs, almost all drugs in psychiatry are developed by the private sector. Academia doesn't really develop many drugs in psychiatry. It's mostly in the private sector. And the private sector would not be really allowed to raise money. Can you imagine being a shareholder in a company that's engaged in illegal behavior? I don't think you'd be too happy with that. But now this has been sanctioned by FDA. The FDA, of course, is the U.S. regulatory authority, but they really are the voice of the world when it comes to regulating drugs. And when they opened the door to considering applications that included psychedelics and also opened the door to even thinking about these drugs as possible breakthrough, that permitted the private sector to raise money, to conduct the studies in academic centers. So I think you're seeing this stigma has been reduced. I think you're seeing legitimacy increase. You've seen a changing political and legal environment. At the same time, I think we all need to be very, very careful. And this is an important message. Psychedelics, psilocybin, LSD, DMT, ayahuasca, none of these drugs have been fully shown to be effective and safe in any mental illness. And so it would not be appropriate to be recommending anyone take these treatments. The only reason someone should take something like this, I could imagine if you're a participant in a clinical research study, for example, being done for scientific purposes. Sometimes for example, in Canada, Health Canada has special access for people who have really just terrible illnesses, sometimes end-of-life situations, where, in fact, I think we're trying to offer peace and solace to people. That's a very different conversation while we're offering those treatments out of humanitarian reasons. But taking them just simply because you watched Reddit or you heard on Netflix that Nicole Kidman's doing great on them, I don't think that would be supportive efficacy or safety data. And I would strongly discourage that. But who knows? Certainly what's happening in the scientific community right now as we speak, over 100 studies across many mental disorders. Some are close to the finish line. So we're going to have some, I think, answers, yes or no answers, as whether this is truly effective and safe very soon.
You mentioned Health Canada and their take on it. What is their standpoint on the use of these drugs? Is it kind of similar to that of the U.S.? Because it does recognize the potential health benefits of taking these drugs, but it always says proceed with caution and talk to a healthcare provider. It's not that black and white, as you said. It's not a yes or no. What is their standpoint on psychedelics?
Well, I think that, their standpoint, I suppose, would be surmised from their policies in the sense that their policies do provide special access availability. So I suppose that would speak to their thought process, I would hope, insofar as they have adjudicated the science and have determined that for Canadians, in certain situations, there would be exceptions where they could have access to a drug like psilocybin, for example, to alleviate their suffering and whatever may be the cause of that suffering. It would also be, if my understanding would be, I really hope it would be Health Canada's position that Canadians should not be taking psilocybin or other psychedelics outside of this situation or being a participant in the clinical research study. And that would certainly be the position of the Food and Drug Administration. It remains federally an illegal substance in the United States. The states determine at the state level some of the legalities about access. That's more complicated, I suppose you could say. But for now, Health Canada has certainly provided my group in Canada the first ever randomized controlled trial with a psychedelic in Canada, psilocybin and depression. Of course, this is approved by Health Canada, so they're supporting rigorous research in the area, evaluating safety and efficacy. But I think it's under very exceptional circumstances that Health Canada would say that there could be a reason to use it. And I certainly hope that is their position, because that would be certainly my position as well.
Let's discuss the risks of using psychedelics. One of them being psychosis. Can you elaborate a little bit about what could go wrong, whether that's with, low dosage or regular dosage, maybe prolonged usage, a laced dose?
Yeah. Well, I think, first of all, let's just start off with what's the risk of mental illness? The risk of mental illness are serious. In fact, around the world, mental illness is the single largest cause of loss of human capital. People can't complete their school, can't go to work. They lose their health. They lose their lifespan. Mental illness is the great cancer to humanity, quite frankly. So we need treatments that are effective and safe. But the evidence base always needs to be robust, because that is what's required before we can support a treatment. So efficacy matters, but so does safety. Sometimes I hear that psychedelics have no side effects. Well, that's curious, because when I give someone placebo, the rate of side effects are 60 to 70%. So clearly, side effects affect everything. The rate is 60 to 70% on placebo. So everything has side effects. The question is not that. The question is, on the balance, does the efficacy and the safety, does that balance warrant considering this treatment? And obviously that calculation is different for every disease we consider. So now more narrowly looking at the safety, there are some short-term safety concerns. We're taking psychedelics, your blood pressure could go up. You can get some gastrointestinal side effects, some headaches. Those are not usually considered major problems. But coming back to what you said, some people have what's called flashbacks or trips, and they have, there's a medical term for it called the HPPD, but they can have flashbacks. It's not common. Type 1, Type 2 flashbacks can occur. Some are mild, which are type 1, more severe is type 2. We don't really know how common they are, probably more common with some psychedelics like LSD more than others, maybe a few percentage points, but nobody really knows. Whether or not people get addicted to these drugs or and so on, they don't appear to have a high abuse liability in animal models and humans so far. But again, that needs to be ascertained. So taken together in the short term, there's also inconvenient side effects. Some people can have bad trips, which can be very, very awful for them and very disturbing, accompanied by a lot of anxiety and depression. That's more of the psychological side effects, but there's some physical side effects. But what we're especially interested in is aspects around what percentage of people become psychotic on these drugs. In other words, while they're taking them or later on called a flashback. What percentage of people, if any, have heart-related problems on these drugs? And thirdly, what is the long-term safety and tolerability? Nobody really knows. And so that's still being sorted out. But what's there so far is reassuring. It's very reassuring. But we can't just go by, well, we think it's safe, and I heard on Netflix it's safe, therefore it must be safe. That would be abandoning the responsibility we have out of respect of the seriousness of the mental disorders.
I'm curious to know, because you said that when people take psychedelic drugs, it's basically like a reset or a reboot to the system. When they do have a bad trip, though, when people, when it gets ugly, what happens? Like, does the reboot not work? Or like, in just, I guess, like non-scientific terms, like what happens to the reboot in that situation?
Well, just imagine you use different metaphors. You've got a system, you've rebooted the system, and for the most part, it's back on track, but not every thread necessarily is back on track. Okay, so we'll go with that metaphor, so to speak. I think what we could say is that, look, these are drugs that get into the brain. These are drugs that are affecting the brain circuits, the brain networks that you and I depend on to think, to feel, and to behave. And so this is serious stuff. And we are still far from complete in our knowledge on exactly how these drugs are working. It's a work in progress, but we do have some nice insights. Secondly is we are far away from being very precise in how we're targeting the brain with these drugs. So we have a phrase in psychopharmacology called on target, off target. So just like when you go to the shooting range, you want to shoot right at the target. If you miss the target, you're off the target. And we would love to be like a laser right on the target. Sometimes we're not quite on the target. And so some hypotheses are that these types of flashbacks and other undesirable effects might represent some of the lack of precision that these drugs have in the brain. That's one theory. A non-competing theory could be that maybe this is because you have recalibrated the circuit. And for some people, that could actually have kind of an unexpected reaction. You may have, in fact, then resulted in having a greater propensity to this. So the plot is thickening. We're still trying to understand the plot here. It's thickening. But what we take away is that it's probably because it's an imperfect correction. Secondly, it's probably because we're not as laser sharp in how we're targeting on the receptors as we would like to be.
I want to discuss a recent study out of North America. It found some health benefits in treating anxiety with the use of LSD acid. Now, the study didn't use a low dosage. It used a regular dose of psychedelics. But putting acid aside for 2 seconds, what are currently the most common ways to treat anxiety that's acceptable in the medicine world?
Good. It's a good part to start with. The evidence-based treatments for people who live with an anxiety disorder. Keep in mind that anxiety comes in different shapes and sizes. So when we talk about anxiety in medicine, we're typically talking about generalized anxiety disorder. And the treatment of choice is psychotherapy with cognitive behavioral therapy. It's a very effective treatment for it. There are Health Canada, there are FDA-approved medicines for that, which are the SSRI type drugs and SNRIs. These are drugs that we also use for depression. And that has been the conventional approach for quite some time. But many people don't respond, don't benefit adequately. There's an appetite to have more treatments for anxiety. And as you probably know, since the pandemic, the rates of anxiety went up and they kept going up and up and up. And frankly, this is a very anxious society. There's a lot of things going on right now. So LSD, which you made reference to, at least a proprietary formulation, was studied and shown to be very effective in the acute rapid alleviation of anxiety, GAD, type anxiety, generalized anxiety, and it sustained itself out for a couple of months. Here's the part that's interesting. It's a different issue we kind of haven't really spoke to. And that is the benefit on anxiety did not depend on the person necessarily having a trip. And this is a separate issue. Some people hold very strongly the belief system that the trip is the active ingredient necessary to have a benefit for mental illness. That would be a testable hypothesis. We don't even know that's true. In fact, we have a lot of psychedelics we're developing that don't even cause trips. There's psychedelics without the trip, and they're looking very good. And LSD, at least the study I think you're making reference to, just published recently, a rigorous, small but rigorous study, showed benefit. And again, the benefit on anxiety did not necessarily require that trip.
You mentioned that appetite for alternative medicine. In your opinion, are there certain people that maybe aren't fit for using psychedelics to treat mental, disorders, or are maybe people that have predetermined health conditions, both mental or physical?
Yeah, the answer is yes. That's a fantastic question. And, I think that this is so important because we don't want to bring harm to people. And at this juncture, what I would say is that if you're someone who's living with schizophrenia or someone who is susceptible to experience what we call psychosis, and just to be clear, because there's so much nonsense out on the internet as what psychosis is. Psychosis means you are not in touch with reality. In other words, the person has delusions, they have beliefs that are not based in reality, paranoid, often grandiose. They may have hallucinations, which means you're having a perceptual experience in the absence of a sensory stimulus, so you hear voices or see things. That person should probably not be getting psychedelics, at least for now. Secondly is some people are especially vulnerable when they start losing control of their mental faculties. It's not an uncomfortable feeling to lose control for all of us, or most of us at least. Thirdly is some people, because of their personality and or their past history and or for other reasons, the notion of losing control of their mental faculties, which is a phenomenon that occurs subjectively when you take a lot of these psychedelics, is so overwhelming to maybe even do psychological harm to them. Could be even traumatizing. And again, that's a judgment. That's those lines in the sand are not easily drawn, who that person necessarily is. It's like a lot of things in life. You know who it is when you see it, but it's hard to define it. And so that would be a person I would certainly be very, very cautious around using these particular drugs. So for now, your question, I would even say, is even more important than who is the right patient.
Do you think there's a future where using psychedelics, both in a regular dosage or a low dosage, to treat mental illnesses become the norm?
Well, I don't put the norm, but I think it would certainly be an opportunity. Look, mental disorders, as we talked about, are serious. They're debilitating. We've got good treatments. That's the good news. Some people do really well. I've done this for a long time. I've been treating depression and bipolar disorder for almost 30 years. It's exhilarating to see people do well on the treatments. But the other truth is a large percentage don't, and we need new treatments. And what we have right now is we have some lead candidates. You mentioned LSD earlier. We talked about that. DMT is also looking interesting, dimethyltryptamine for depression. Finally, psilocybin. Those are the lead candidates right now within the so-called serotonergic psychedelics in depression. And my fingers are crossed that they could get what we say over the wall. They could be positive, because that would provide for people an opportunity to have a treatment that they need. And I think we need new treatments. So that's very exciting and very hopeful. There are some sort of dirt under the fingernails or boots on the ground, whatever phrase you want to say, questions that still need to be sorted. Who's going to pay for this? And the other part is how would I get access to it? We know already in Canada, most Canadians cannot access new treatments because of affordability barriers and so on. How's that going to play itself out? We already, in Canada, we have an egregious wait list to see anyone for mental health related problems. So how the heck am I going to get my treatment in an accelerated way? And these are sort of real world questions that have not been sorted out. And then finally, something we just touched on briefly, conceptually, but very important clinical questions that relate to access and reimbursement is, if trips are required, which we don't know yet, it's still a hypothesis, how's that going to fit into the healthcare system? Who can do all this? So these are all important, and this is not a full list, but enough questions that still need to be sorted out. But look, we need new treatments, and we got some lead candidates in the serotonin psychedelic space in some conditions like depression, anxiety, and a few others. I'm hopeful if we get one over the wall or more than one, that's another treatment for people who struggle. And that's a good thing, but we still need to think about how we're going to roll this out if we can get it over the wall.
I'm going to leave it at that. Dr. Roger McIntyre, professor of psychiatry and professor of pharmacology and toxicology. Thank you so much for joining us today.
Oh, what a pleasure to be with you. Thank you.
And that was The Big Story. If you found this episode interesting, be sure to share it with a friend or someone you think may like it. We always appreciate feedback. If you have any, send it our way at hello@thebigstorypodcast.ca or leave a comment on this very episode. You can get The Big Story daily on the Seeker app or wherever you get your podcasts. I'm Maria Kestane. Thanks for listening.